Hello friends, this is Dr. Sangeeta from Dental Pathshala, where we help you understand and learn dentistry better and easy way. And today we are going to be going over the most common injuries in the primary teeth. In today's lecture, we will understand these terms: the enamel fracture, enamel dentin fracture, complicated crown root fracture, uncomplicated crown root fracture, concussion, subluxation, extrusive luxation, lateral luxation, intrusive luxation and avulsion. And by the end of the video, you will know how to treat these injuries and what is the classification for traumatic injuries in primary tooth. So let's get started. Before we get started, make sure you subscribe to this channel and click on the bell icon. Ghanti zarur baja de. That way you get a notification as soon as I release a new video lecture. Traumatic injuries to the teeth occur at any stage. They are, however, very common in the children. And if we look at, the boys usually have twice as many as injuries seen in the girls, both in the primary as well as in the permanent dentition. Now, the majority of the injuries affects the maxillary incisors. The most common teeth which is affected during the injury is the maxillary incisors. And if you see, the type of injury which is seen in the primary dentition is subluxation and the luxation injuries. So most common injuries which are seen during the primary teeth is the luxation and the subluxation injuries. While if we look at the permanent teeth, the most common injury which is seen in the permanent teeth is the crown fractures. So 2 to 4 years of age, a child is more prone to injuries to maxillary incisor. Actually, a child is exploring and he is becoming adventurous at this point of time, at this period of time. So he is more prone. This age is more seen with the primary teeth, in the injuries in the primary teeth. And 7 to 10 years, if we look at the permanent dentition, actually we are seeing injury in the permanent dentition as the childs are going to fall during this period of time while playing. So the very first thing we do, we ask some questions. We take the history of the patient while a child patient comes to you at your dental clinic with the injuries. So the first thing you ask is the history of the patient. The very first thing when the child enters your dental clinic with the injury is, you ask, when did this injury occur? Where did the injury occur? It indicates if there is any need for a tetanus injection. Now, how did the injury occur gives us the idea about the nature of the accident and the type of injury which we are expecting. Now, we also ask a patient if the patient has lost any teeth during the injury or any fragments of the teeth. We also ask for any headache, vomiting or amnesia, and we also ask for any previous trauma, any previous dental history of trauma. So this gives us idea, and also we run some pulpal sensitivity test if required. So we'll come across certain terms in this chapter. Let's go through these terms. The first one is the enamel infraction. It's just a crack. It is a crack in the crown. So this is enamel infraction. Now there is no loss of tooth substance in this fracture. Coming to the enamel fracture is where there is loss of tooth substance, there is fracture of enamel. Enamel dentin fracture is where there is loss of tooth substance at the enamel and the dentin, but not in the pulp. So enamel plus dentin is fractured or is involved, but not the pulp. So coming to the complicated crown root fracture it is the fracture of the enamel and dentin, exposing the pulp. Now in this, pulp is exposed. So pulp is exposed in the complicated crown root fracture. Coming to the uncomplicated crown root fracture is the fracture of the enamel, dentin and the cementum. So enamel, dentin and cementum, but it doesn't involve the pulp. Pulp is not involved in this. Coming to the root fracture, we have is a fracture of dentin, cementum and the pulp. So all these three are involved, and it is also further subclassified into the apical third, middle third and the coronal third. Now coming to the injuries to the periodontum, periodontal tissues. So concussion is when there is no abnormal loosening or displacement. Now there is no displacement of the teeth. Teeth is not displaced from its location, but it is marked reaction to the percussion. So it is tender on percussion is positive for concussion. There is no displacement of the teeth. Teeth is at its position, but there is tender on percussion is positive, but marked reaction to the percussion. Now coming to the subluxation. Subluxation we also called as the loosening. Now the teeth is loose, but there is no displacement. There is no displacement. Displacement is not present, but the teeth is loose. Coming to the extrusive luxation is partial avulsion. It is the partial avulsion. Avulsion means when the tooth comes out. So it is just the partial, not the complete avulsion. Complete avulsion we'll discuss later on. So this is the partial avulsion of the teeth, in which there is partial displacement of the teeth. Displacement is present, but it is partial. So partial displacement of the teeth from the socket. Coming to the lateral luxation is when there is displacement but not in the apical direction. It is present in the lateral direction. So there is displacement other than the apical direction. So there is displacement or the fracture of the alveolar socket. Now coming to the intrusive luxation is when there is displacement present into the alveolar bone or fracture of the alveolar socket. Coming to the avulsion is when the tooth completely comes out of the socket. So there is complete displacement. The displacement is complete in avulsion. So there is complete displacement of the tooth from the socket. Now the tooth has come out of the socket. So let's just go through again. So enamel infaction is when there is incomplete fracture of the or crack of the enamel without any loss of the tooth substance. It's just the fracture of the it's just there is a crack in the enamel, not the fracture, just a crack in the enamel. Enamel fracture is when there is loss of tooth substance which is confined just to the enamel. And enamel dentin fracture is when there is loss of substance which is confined to the enamel and to the dentin, but pulp is not involved. The complicated crown root fracture is, it is the fracture of the enamel and dentin and pulp is exposed. Uncomplicated is when the fracture is not complicated and it can be managed easily. So when pulp is not involved, it can be managed easily. So we can remember it as uncomplicated crown root fracture. Root fracture is when there is fracture involving the dentin, cementum and the pulp, and it can be subclassified into the apical third, middle third or the coronal third. Concussion is when there is no loosening or there is no displacement, but tender on percussion is positive. Once we tap the tooth, there will be pain on tapping. So tender on percussion is positive. There is marked reaction to the percussion. Subluxation is loosening. Loosening and there is no displacement. Loosening is present but tooth is not displaced from its position. Extrusive luxation is the partial avulsion of the tooth. Now it is the partial avulsion and there is partial displacement, we can say. Lateral luxation is when there is displacement other than the axial direction, and the intrusive luxation is when there is displacement into the alveolar socket. Now coming to the avulsion, which is the complete displacement of tooth from the socket. So these all are the terminologies. And let's go through the classification of the traumatic injuries. To the classification of the traumatic injuries in the primary teeth. So remember, we are just talking about classification of the injuries in the primary teeth. We are not talking about the traumatic injuries classification or traumatic injuries classification in permanent teeth. All three classifications are different. If we are talking about traumatic injuries, then we will talk about the Ellis classification. But today's video we are talking talking about traumatic injuries in the primary teeth. So the classification which we are talking about is the classification of the fracture of primary teeth, which is the teeth is given by Garcia in 1981. So class 1, which is the fracture of the enamel. This is the fracture of the enamel. Class 2 is where there is enamel plus dentin fracture. Now class 3 is when the enamel, it's more like Ellis classification, but it will get different. So this is enamel plus dentin plus the pulp. Now class 4 is when there is enamel, dentin plus cementum sometimes. Now the 5 is, it's not the root fracture, 5 is the root fracture. 5 is the root fracture. 6 we have is the concussion. And 7th we have is the luxation. Now we all know these terms. And 8th one is the extrusion. So the tooth is extruded, extrusion. And the 9th one is the avulsion. This is not the Ellis classification. I am reminding you again, this is the classification of the fracture of primary teeth given by Garcia Godoy in 1981. So 9th one is the avulsion. Let's go through it again. Class 1 is the enamel fracture. Class 2 is the enamel and dentin fracture. Class 3 is the enamel, dentin and pulp fracture. And class 4 is when the enamel, dentin and cementum is involved. 5 is the root fracture. 6 is the concussion. 7 is the luxation. 8 extrusion and 9th avulsion. Also there are other classifications. There is a modification of Ellis classification by MacDonald and Avery. Now this classification is class 1 when there is simple fracture of the crown with little or no dentin involved. Class 2 is, this is the modification of the, this is not, see remember this is not the Ellis classification, this is the modification of the Ellis classification. And if you all know the McDonald's book of pedodontics, pediatric dentistry, so this is the classification of MacDonald Avery. Now the class 1 is when there is simple fracture of the crown, when there is little involvement of the dentin, little or no dentin. And class 2 when there is extensive fracture of the crown which involves the dentin but not the pulp. Now pulp is not involved, there is fracture of the enamel plus dentin. And class 3 is when there is extensive fracture of the crown, in which, as you all know, third is always enamel plus dentin plus pulp is involved. And the 4th one is when there is entire loss of crown. There is entire loss of crown. So this is the modification of the Ellis classification by McDonald's and Avery in 1983. So we have covered 2 classifications. One classification is the fracture of the primary teeth given by Garcia Godoy in 1981, and the other one is the modification of the Ellis classification by McDonald's, Avery and Lynch in 1983. Again we'll go through the modification of Ellis classification. Class 1 is just the crown is fractured. In simple words we can say crown is fractured. In second one is there is a simple crown fracture means there is just the fracture of the enamel. So 2 is enamel plus dentin is fractured, 3 is enamel plus dentin plus pulp, and 4 is when there is entire loss of the crown. So these are the classifications of traumatic injuries in the primary teeth. If we talk about the treatment, now coming to the treatment of these classifications, so we'll go through one by one. Coming to the first one, when there is only fracture of enamel. When there is fracture of enamel, generally no treatment is needed. The tooth is actually evaluated time to time. Usually the time is 6 months. But if the enamel is chipped off, imagine when the enamel is chipped off. Now these sharp edges impinge the tissues. So these tissues can be smoothed or round off, and also you need to apply fluoride. Fluoride application. Let me write it with this pen. So we apply fluoride. Fluoride application. Also you can apply acid etch composites and restore these chippings, the small or if there is large chipped, then you can apply the composite for the aesthetic reasons. If there is considerable loss of tooth, if enamel loss is much, then you can give a stainless steel crown to the patient, or also you can give the strip crown acid etch technique when there is severe loss of enamel. And also the periodic checkup at the stainless steel crown for the extensive loss of enamel, and 6-month checkup, periodic recall you should call the patient, because sometimes the tooth undergoes internal resorption and which may need extraction. Now pulp sometimes become necrosed in later on stages, and it may require root canal or extraction at that point of time. So you should periodically recall the patient for 6 months at the 6-month time for checkup. Now coming to the second one, we have when there is fracture of enamel and the dentin. Now the radiograph, you should take radiographs whenever there is a fracture case coming up. So radiograph determines you the extent of the injury, whether it is confined to the dentin, whether it is confined to the pulp. So a radiograph is mandatory, and a restoration is mandatory when there is fracture of dentin, because you need to seal the exposed dentinal tubules. Now the dentinal tubules are exposed and you need to seal these, and you can do it with the help of calcium hydroxide or GIC cement. And you should apply calcium hydroxide or GIC as soon as possible after the trauma. And if there loss of tooth structure or there is extensive loss of tooth structure, then you can restore with the help of polycarboxylate crown, or you can bond it with the composite restoration for aesthetics. Now coming to the third one, we have when there is fracture of enamel, dentin and pulp. Now this fracture, of course, you need to take a radiograph to see the extent of the pulp and to see the extent of the injury for the pulp, and also it gives you the idea if the pulp can be rescued with the help of pulp therapy or not. Now the pulp capping procedure, the direct and indirect pulp capping procedure are usually not recommended in the primary teeth, but you can do the pulpectomy procedure. Now pulpectomy procedure can be done with the help of ZOE cement, or you can use the Vitapex. Now pulpectomy procedure will make another video for pulpectomy because it's important topic for you guys. So we will discuss pulpectomy in some other video. So for enamel, dentin and pulp fracture, you can do the pulpectomy procedure using zinc oxide, eugenol or Vitapex, provided 2/3 of the root is present. Now you can only do this when 2/3 of the root is present. And in case if you see there is any risk for the developing permanent teeth, if it is closer to the developing permanent teeth, then you should go for an extraction. And while performing the extraction, you should make sure that it should not damage your permanent tooth bud. Now you should call the patient again for periodic checkup for 6 months. Root fracture is rarely seen in the primary teeth. You should take a periapical radiograph, and this will give you a positioning about the fracture. If you remember, we have studied the subclassification of the root fracture, which is the apical third, the middle third or the coronal third. Now you are very lucky if the patient is having a fracture at the apical third, because apical third fractures have good prognosis. So if the patient has a fracture in the apical third, then you are lucky and it has a good prognosis. And because it usually resorbs normally, this fracture at the middle third and the tooth is mobile, you need to extract the tooth. Concussion is usually not brought to us until the tooth get discolors. Now luxation or subluxation we'll talk about. So before luxation, let's talk about how to treat the subluxation when there is loosening of the teeth. If the tooth is slightly mobile, then a soft diet, we should advise the patient 1 to 2 weeks of soft diet. And the traumatized area should be cleaned as possible. Now if there is marked mobility, then you should go for extraction. Coming to the luxation, we have extrusive luxation, lateral luxation, intrusive luxation. All these three will talk separately. Extrusive luxation is the marked mobility, and of course it requires extraction. Coming to the lateral luxation if the crown, now there are two scenarios. Okay, if the crown is displaced palatally, suppose this is the crown, and if the crown is displaced palatally, that means the root is displaced buccally, right? If the crown is displaced palatally, that means the root is displaced buccally, and it is away from the permanent tooth bud. Now when this is away from the permanent tooth bud, that means we got lucky, because if the occlusion is not gagged, then conservative treatment we can do and realignment is possible. But if the crown is displaced buccally, that means the root is gone palatally, and then if the root is gone palatally, that means there is a risk for permanent tooth bud damage. That means we should extract the tooth to prevent the damage for our permanent tooth bud. So talk about intrusive luxation, and it is the most common type of luxation. Again, when the tooth is displaced palatally towards the permanent tooth bud, then the primary tooth should be extracted to minimize the possible damage to our permanent tooth bud. And if the root is displaced buccally, then we should monitor it and it will re-erupt. We should give the time to re-erupt the tooth, and we should review the teeth weekly for a month and then monthly for the 6 months. So first 1 week, we should call 1 week for a month, 1 month, and then every month for 6 months. So this is how we should recall the patient. And most of the re-eruption actually occurs between 1 to 6 months, and if this doesn't occur, then there is most probably chances of the tooth getting ankylosed, and extraction should be then done to prevent the ectopic eruption of the permanent tooth. Now coming to the avulsion, or you can say X-articulation. When the tooth has come out of the socket, we actually re-implant the tooth into the socket, but it is not recommended for the primary teeth because there is risk of damage to the permanent tooth germs. So we don't do avulsion, we don't re-implant the avulsed tooth for the primary teeth. We do it for the permanent teeth. We don't do it for primary teeth. Remember this. We don't do it for the primary teeth. Space maintainer actually is not necessary, because if we talk about primary incisor, then there is minor drifting of the adjacent tooth. So the tooth doesn't drift so much. So there is not much requirement of the space maintainer, and eruption of the permanent teeth may delay for about an year. So this is about injuries in the primary teeth. If we talk about the sequelae of injuries, the most common problem, the most common complication of the injury after the primary teeth is the necrosis. We also see pulpal obliteration, root resorption, or sometimes injuries to the permanent teeth while during extraction. So that's about the traumatic injuries in the primary teeth. I hope that I helped you understand the traumatic injuries in the primary teeth, and we'll separately talk about Ellis classification, avulsion in the upcoming videos. So if you have any questions, you can leave it in the comment below. And if you enjoy the video, like it, share it with your friends, subscribe it, and I'll see you soon. Stay home, stay safe.